Should patients be on high-dose methadone? And if so, what needs to be done to protect them?
The issue around methadone dose has been a challenging one for quite some time, and most of the studies pretty much reflect that higher dose methadone is much better for treatment retention, improves treatment outcomes, and they have less drug use. So overall, there's probably a good rationale to put patients on high-dose methadone. The problem is what is high-dose methadone? And for patients with HIV, especially if they're on a non-nucleoside reverse transcriptase inhibitor that induces cytochrome P450, reduces the levels of methadone, and it therefore requires an increase in the methadone probably by 40 to 50% higher than you would ordinarily do in order to sort of achieve the same level of control. So it seems as though many patients with HIV are on extraordinarily higher doses of methadone than other patients. Now, the big concern with higher dose methadone is that it can result in some negative consequences. And the biggest one that we're concerned about is cardiac arrhythmias, specifically prolongation of the QTc interval and ultimately torsade de pointe. And the question is how do we actually make sure that our patients aren't at risk? Well, first of all, it's not going to be a common occurrence. Probably less than 2% of patients on methadone are going to be at risk for a prolonged QTc interval anyway. But there are a number of risk factors that are associated with that, and that is, do they have any underlying cardiac disease? Do they have end-stage renal disease or end-stage liver disease, any sort of electrolyte abnormalities, et cetera? So what is recommended is in patients who are initiating methadone, we probably should check an ECG or cardiac cardiogram before initiating methadone right up front. And if their QTc is less than 450 milliseconds, they're probably going to be fine. For other patients who have risk factors, though, or their baseline QTc is more than 450 milliseconds but less than 500 milliseconds, those patients should probably have monitoring of their ECG probably 2 to 4 weeks after initiating methadone, and then if their dose gets to be 100 milligrams or more, we should probably recheck it again. So that's one of the ways to minimize it. Once their ECG goes up to 500 milliseconds or longer, they have a 4 to 8-fold increased likelihood of having a cardiac arrhythmia and potentially death. And so for those patients, they should come off methadone immediately. And there are other evidence-based treatments for opioid dependence, specifically buprenorphine, and extended-release naltrexone. So we do have other treatment options. So I think that in general, it's important to do proper screening, to really discuss the risks and benefits of methadone, and to offer alternative options for those patients who are especially at high risk for having complications from treatment.